Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show hosts or the guests are their own. Enjoy the show. Welcome to MS&Me Interviews. I am your host, Erica Lyons Richardson. This week, we continue our series focusing on some of the research and MS treatment innovation presented at ECTRIMS 2018, held in Berlin, October 10th through the 12th. For a quarter of a century, ECTRIMS has served as Europe's and the world's largest professional organization dedicated to the understanding and treatment of multiple sclerosis. The ultimate goal of ECTRIMS is to improve basic and clinical research and clinical outcomes in multiple sclerosis. For those in the U.S., there is a sister conference, ECTRIMS, for which MS&Me Media was pressed earlier this year. In interest of keeping our show patient-friendly, I will do a short summary of some of the MS research presented at ECTRIMS. 3 days of mounds of science compressed into an easy-to-understand review from a patient perspective. So let's get started. Our first topic, in clinically isolated syndrome patients, early lesions in specific brain areas linked to worse disability 30 years later. Lesions in the infratentorial region of their brain at the onset of clinically isolated syndrome, or CIS, and lesions in white matter 1 year after CIS onset are associated with worse disability 30 years later. This according to the study presented at ECTRIMS. Unlike most MS patients who experience neurological impairment over time, some develop little disability even after 20 or more years. Given the scarcity of MRI studies on predictors of long-term MS outcomes, a team from the UK and the Netherlands assessed early MRI predictors of disability 30 years after the onset of CIS. CIS is that first attack on the myelin in the central nervous system lasting at least 24 hours. This often precedes the diagnosis of MS. The study used data from the 30-year follow-up of the first London CIS group. It assessed specific MRI-detected brain lesions and lesions located at baseline and at 1 and 5-year scans. Disease course at 30 years was classified as CIS. MS with an EDSS score, or Expanded Disability Score, of 3.5 or less, MS with an EDSS score higher than 3.5, or death due to MS, an EDSS score of 10. Outcomes were known for 120 of the initial 132 participants, or 91%. After the mean period of 30.1 years. At 30 years, 40 participants had CIS, or 33%, and 80 had MS, which was 67%. Among those with MS, 35, or 44%, had relapsing remitting MS, while 26, or 33%, had secondary progressive MS. MS contributed to the death of 16 patients, which was 20%, and 3 others, 4%, died of unknown or unrelated causes. In total, 32 patients, which was 27%, had an EDSS score of 3.5 or less, all of whom had not progressed beyond RRMS. Infratentorial lesions at baseline and deep white matter lesions at 1 year were the most significant early MRI predictors correlating with EDSS score greater than 3.5% at 30 years. Okay, our next topic. Lowering the risk for PML. Professor Walter Atwood of Brown University was interviewed at ECTRIMS. He discussed innovations in the treatment of PML. Reactivation of the JC virus, or John Cunningham virus, under conditions of immunosuppression leads to often fatal demyelinating disease in humans, which is known as progressive multifocal leukoencephalopathy, or PML, which is much easier to say. There had never been an identified case of PML in patients with JC virus until the development of immunosuppressant medications, the DMTs. There have been many of new medications in trials to treat PML. The serotonin receptor antagonists have all failed. The struggle has been that patients in these trials have already developed PML, and they are very sick. So now what is showing promise is treating with teriflunomide. There are many viruses that have been shown to be inhibited by teriflunomide, both RNA and DNA viruses. So it inhibits the virus from replicating. That's the key. This is promising work being done in this area. So look for more research coming on PML and new treatments. Our next topic. Relapse after stopping fingolimod occurs frequently. Multiple sclerosis patients who stop taking fingolimod, which is Gilenya, for pregnancy or other reason experience a high risk of disease recurrence, often resulting in diminished functional status. Researchers reported this at ECTRIMS from their study. Clinical and or radiological recurrence of the disease activity occurred in about 35% of cases, while severe recurrence of the disease activity was observed in approximately 11%. Within 6 months of discontinuation, 38 or about 35% of the patients who discontinued the Gilenya experienced 41 events. The median time to disease recurrence was 8 weeks. Of the 443 patients, 110 who discontinued treatment experienced 118 fingolimod events. About 40% of the patients stopped fingolimod and did not take another disease-modifying treatment. The others were switched to another DMT. Participants had different reasons for stopping the drugs, including disease activity, 52 of them, adverse side effects, 25 of them, pregnancy or childbearing preferences, which was 19 of them, among other reasons. Now, larger and independent studies are necessary to further validate the potential risk factors for reoccurrence of the disease activity after fingolimod discontinuation. It's important to note that the patients were only followed for 6 months, so that and the fact that they switched to a new DMT may account for the fact that they did not have the more severe attacks after discontinuing the Gilenya. Okay, our next topic. This is a very hot topic these days, and also has been the unfortunately the target of some not so valid treatments, and they're using the name of stem cell, but they're not actually treatments that are effective for the treatment of multiple sclerosis. So let's learn about the type that is. Stem cell transplant effectively lessens the disability in patients with aggressive MS. The treatment with the AHSCT led to safe and rapid lessening of disability and no clinical relapses in patients with aggressive MS. This according to the study that was presented at ECTRIMS. AHSCT is a procedure that involves collecting the stem cells from a patient's bone marrow, peripheral blood, or umbilical cord blood followed by a partial or total impairment of the immune system with a conditioning regimen called immunoglobulation. And then infusing the stem cells back into the patient to reconstitute and reactivate the immune system. This method has been very effective in patients with highly active relapsing MS. So this was not studied in progressive patients who have failed to respond to standard disease-modifying therapies. The European Society for Blood and Marrow Transplantation guidelines recommends its use as a first-line therapy in patients with aggressive MS. This is severely aggressive forms for which no other treatments were effective. Aiming to address the procedure's safety and effectiveness as a first-line strategy among these patients, the study focused on 20 with aggressive MS who received the AHSCT at 5 centers. 7 patients in Sheffield, UK, 7 in Uppsala, Sweden, 4 in Ottawa, Canada, 1 in Florence, Italy, and 1 in Chicago, Illinois. No patient received any standard DMT for more than 3 months before AHSCT. Patients were treated with either beam chemotherapy plus ATG to lessen the transplant rejection, the cyclophosphamide, I think it's called, with ATG, or a triple combination of cyclophosphamide, ATG, and busulfan were used as conditioning regimens. Patients had a mean age at diagnosis of 28 years, range of 19 to 52 years, and a median pre-HSCT expanded disability status scale, or EDSS score, of 6.5, which means requiring 2 walking aids to walk about 20 meters without resting. The higher EDSS score and greater the patient's disability. Okay, so the higher your EDSS score goes, the greater the patient's disability on a scale of 1 to 10, 10 being death from MS. Median follow-up duration was 29.5 months. Patients showed a statistically significant median EDSS score improvement or reduction of 2.5 between pre-HSCT and the last follow-up visit. The median EDSS score at the last visit was 2.0, which indicates a minimal disability level. No patients had post-transplant disability progression. No patients experienced a clinical relapse following the AHSCT. New brain and spinal cord lesions were found in 3 patients during the first follow-up visit using the MRI scan, but no further lesions were found in subsequent scans. MS brain, it's kicking in there. Now, treatment with AHSCT led to routine toxicity, but did not cause death, as in previous studies. To further support the successful approach with AHSCT among the patients treated, 1 female naturally conceived and gave birth to a healthy baby, and 1 male patient had fathered a healthy baby during the study. Overall, the team concluded AHSCT was a safe and highly effective in reducing and sustained remission in that study and was associated with a significant improvement of patients' level of disability. This demonstrates that the potential role of AHSCT as a first-line therapy in aggressive MS. Now remember, it's not in other forms, just RRMS. It's very aggressive course. Now also remember, this procedure has been around for decades, but it has a history of deaths and efficacy issues. This is why they're only recommending it for aggressive cases at this time. Also, this is not a cure. It is a treatment like any other DMT. There are long-term impacts from the chemo, and it has to be weighed against the possible benefits. Another warning is that the bogus stem cell therapies without chemo that are in no way approved for treatment for MS. These centers are popping up all over the world. They are not true treatments for MS. They are just in these little centers that claim that they are treatments for MS, and they are not. If you're not having chemo to suppress your immune system and then transplant your stem cells, this is not AHSCT. Make sure that you do your research. Our next topic is serum neurofilament light threshold is proposed as a way to identify RRMS patients at risk of worsening. RRMS patients with serum neurofilament light chain, or SNFL, levels higher than a proposed threshold have a higher risk of disease activity and worsening disability, lesions, and brain shrinkage in the long term, according to the new study. SNFL has been suggested as a potential disease biomarker. It is a protein exclusive to our nerve cells and one of the major byproducts found in cerebral spinal fluid and blood after the nerve cell's death. In patients with RRMS, the SNFL levels correlate with disease activity, help predict long-term clinical and imaging outcomes, and are reduced by disease-modifying treatments. Now, however, a standardized method and clinically meaningful limits validated with real-world data are still required to integrate the SNFL into clinical practice with the patients. The result of several studies showed that baseline SNFL levels correlated with the number of brain lesions and accumulation of new lesions on magnetic resonance imaging over time. SNFL levels were consistently low in patients without evidence of disease activity, but were elevated in those with disease activity, especially in those with high rates of brain atrophy or shrinkage. Now, our next topic. Shifting from Gilenya to Lemtrada does not increase risk of relapse. Patients with MS who have problems with Gilenya therapy can be safely and effectively switched to another disease-modifying therapy, like Lemtrada, without major risk of disease recurrence. The researchers did report this at ECTRIMS. 1 year after treatment with Lemtrada, the annualized relapse rate was 0.3% among 77 patients who made the switch from Gilenya. During the previous year in which the patients had been on Gilenya, the annualized relapse rate was about 0.9%, and the relapse rate rose to 1.2% to an annualized basis during the washout period that averaged 1.8 months. The washout period means that period between the time that you stop the treatment with Gilenya and then begin your treatment with Lemtrada. After 1 year, 20.7% of people on Lemtrada experienced a first relapse. That rate was 2.9% after 6 months and 10.5% after 9 months. The patients in the study were required to make a direct switch from Gilenya to Lemtrada and were required to have follow-up examination at least 12 months after receiving their first Lemtrada dose. The patients were followed between May 2017 and June 2018. The participants in the study were about 36.2 years old and had been diagnosed with MS for an average of 12.3 years. The average EDSS score at the time they stopped taking Gilenya was 3.4. The median score was 3. Of the 70 patients evaluated, 50 had new enhancing T2 lesions. 36 of the 60 patients scanned had new enhancing lesions, the gadolinium enhancing lesions. This study and others presented at ECTRIMS indicated that we should not wait a long time for switching to drugs along the lines of Limtrada or Ocrevus. Or Ocrevus is the way most people say it. We should not wait a long time because that allows these relapses to occur. The washout periods are getting shorter and shorter and are proving to be safe. All right? So it is safer to go ahead and switch more quickly to those new treatments. Our next topic, SMART trial results for the treatment of SPMS. The MS SMART trial, a multi-arm, double-blind, placebo-controlled Phase 2b study, compared the safety and efficacy of 3 different active agents in patients with SPMS. This is the study that everyone's been waiting for that has SPMS. This compared 3 different treatments for SPMS. The treatments under investigation were Midamor, Ryutech, and Prozac. A total of 445 patients with SPMS with an EDSS score between 4 and 6.5 were randomized to receive either one of these treatments or a placebo, and they were followed up after 24, 48, and 96 weeks. The primary outcome of the study was changed in the rate of brain atrophy and measured through the MRI scans at baseline and after 24 and 96 weeks. The secondary outcomes included the MRI parameters such as new T2 lesions, as well as their clinical measures such as disability progression and their cognitive decline. The results show no statistically significant differences between any of the treatments and the placebo in the rate of brain atrophy, disability, progression, or cognitive decline. Those of you who do your own research and follow these studies presented at both ECTRIMS and ACTRIMS know that both successful and unsuccessful, like this case, research is presented. So we appreciate hearing, them honestly share when things do not work out as they might hope or as the patients might hope. So in this case, those treatments for SPMS did not hold true to the excitement, and unfortunately they were not successful. They showed no different result than the placebos in the study. So that was pretty disappointing. Now, next topic is the 2 European studies compare Tecfidera Aubagio effectiveness for the treatment of relapsing remitting MS. So these RRMS patients with Tecfidera is associated with fewer new brain lesions at 2 years, lower relapse rates, increased time to first relapse, and reduced treatment discontinuation than with Aubagio. This according to that nationwide study from France and a real-world population-based study from Denmark. The patient group treated with Tecfidera had lower annualized relapse rates and lower risk of first relapse and lower incidence of discontinuation due to disease breakthrough when compared with the Aubagio group. No difference in EDSS worsening were seen. So that was pretty significant difference there. That was great results for that study. Okay, looks like we've come to the end of our time for this week's session. We will continue this series next Sunday at the same time. So we will continue our ECTRIMS review. Next week will be part 3. And all 3 parts will be available on our YouTube channel. So look for MS&Me Radio Media on YouTube to look at any of our on-demand past episodes from our 24/7 Global MS Radio Network. I thank you for joining me again this week, and I hope that you've enjoyed this series and hope it makes a little bit more sense coming from a patient's point of view, because I have really enjoyed sharing this information with you. I love being my own advocate and doing what research I can. And I hope that you too will take this information and be inspired to become your own advocate and research for yourself and learn for yourself. Take the information that I shared and research further. Make your own, conclusions and decisions with your doctor about your treatment. Thank you again, and if you need more information, visit our website at www.msandmemedia.com. That's www.msandmemedia.com. You can also find us on Twitter, Instagram, and of course our forums on Facebook. We have pages and forums on Facebook for patients, families, and friends to learn. We also update you with the latest in MS research and news, keep you laughing through the tough times, and entertain you through our media network. Thank you again, and have a wonderful week.